Hi guys, welcome to these deliberations in obstetrics and gynecology. And yes, I know exam time is here. In a few days, you're going to write your MCA exam or the NEET PG exam. And these tense moments give you an opportunity to remember that you have put in a lot of effort for the last 6 months. So let that effort count. All right. Yes, I know you're tense, you're worked up, and you're uh, unsure of the uncertain. Correct. But this is the time that give yourself the confidence of your own effort, and that should push you through these last few days of tense preparations. So do a very good exam, guys. Let's do a quick fire revision of the subject of gyne, the topics which I feel you should not leave your room without reading. So coming with the first question here, after delivery of the fetal head, if the shoulder doesn't deliver for how much time, that is called a shoulder dystocia. So we know the broadest diameter of the babies is the head, which is the which is the bipedal diameter. And once the bipedal diameter comes out, the next broadest diameter are the shoulders, the biacromial diameter. So once the head comes out and then the anti-shoulder delivers, we know now this delivery will complete. So if the head comes out and the shoulder doesn't come out for, yes, most of you, I'm sure you got this correct. If it doesn't come out for 60 seconds, it is known as a shoulder dystocia. It's obviously because of a large size. It's obviously because of large size of the baby, which can be seen in diabetes mellitus or post-term pregnancy. All right, or a mother who is obese. So yes, when we have this shoulder dystocia problem, we should understand that if it is not coming out, then what we should do, we should call for help. And after that, the first maneuver you should do is the Mac Roberts maneuver. All right, not the suprapubic pressure. The first is the Mac Roberts, and that Mac Roberts involves the flexion of the thigh by more than 90 degrees, flexion of the hip joint. And if that doesn't work, then we give the suprapubic pressure. And once that is also done, and if it doesn't work, then you can do the corkscrew maneuver, that you can rotate the head of the baby and deliver the anti-shoulder from the posterior soft vagina. So that is the Wood's corkscrew maneuver. All right. And if nothing works, then you can put the head back into the vagina. Easier said than done, guys. Then put the head back into the vagina and do a cesarean section. That is known as the Javanese. That is known as the Javanese restitution. All right, guys. Okay, let's take the next one. Which of the following is not seen in a normal cardiac change of pregnancy? Yes, pregnancy is a condition where there is a lot of increase in the volume of the body fluids and the blood volume, and that is going to make a lot of noise in the heart. So there'll be an ejection systolic murmur, a flow murmur, and since there is a lot of volume in the heart, in the left heart especially, then there'll be splitting of the first heart sound, and there'll be also a S3 heard because of the rapid filling of the left ventricle. So yes, you will hear a soft systolic murmur, splitting of the S1 and the S3, which is because of the rapid filling. The S3 is because of the rapid filling of the left ventricle. And a diastolic murmur is never seen. So answer is D. But diastolic murmur is mostly pathological, and I'm sure the cardiologist will teach you much better. But yes, a mid diastolic murmur, which is seen in a mitral stenosis, is a classical diastolic murmur, and in fact, that's the only murmur we read first in our MBBS days. All right. So remember, diastolic murmurs are not normal. Right, guys. So post vasectomy, how long should an alternative contraception be advised? So we know that once you do the vasectomy, beyond the block, there is a the vas segment which is going to have viable sperms for almost 3 months. So post vasectomy, for 3 months, the person should be using an alternative contraception, or 20 ejaculates. Yes, I know. The PSM people will be teaching you from Park and Park, and that says 30 ejaculate. So I have to refer to my Bible, and that is Williams Obstetrics, which will be the book of reference. So yes, Williams Obstetrics says it is 20 ejaculates, and the PSM book says it is 30 ejaculates. And I'm very sure that they're not going to give you both in the exams. I'm very sure that they're going to give you 20 ejaculates. So if there's a choice of, let's say, 10, 20, 40, 50, go ahead and mark 20. And God forbid, if there is a 20 and a 30 in the exam, then go ahead and mark 20, because Williams is a more standard book. Please don't get me wrong here. My best friends in PSM, don't get bugged with me, because I'll have to go with what my book says, right, guys? So mark 20 for now. So that is about the vasectomy. How much money does the patient get for getting a vasectomy done? So in a non-focused state, that is the states like Kerala or Punjab, if a person gets a vasectomy, then he gets a 1100 rupee incentive by the government, and the motivator gets another 200 rupees. So it's 1300 rupee cost to the it's a 1300 rupee cost to the government for doing a vasectomy. It's obviously free of charge for the patient. In fact, he gets some money also in that. All right, guys. So let's move on and see the next question. So, softening of the isthmus is which sign of early pregnancy? A lot of questions coming on this one, the early pregnancy signs. So, I hope you're reading them all. So, Shadwick sign, Shadwick sign is not softening of the isthmus. Shadwick sign is actually the bluish discoloration, of cervix and of the vagina. Please do not get confused and say it is only the cervix or only the vagina. It is classically described the Shadwick sign for the cervix, but it is also a bluish vagina. Okay. Then Hagar sign is the soft isthmus. That is, you put your hand on the abdomen, one hand in the vagina, and through this vagina and the abdomen, your hands, they go through the isthmus of the cervix in a pregnant lady, and your fingers will seem to touch each other through the isthmus of the cervix. So that is what is a very soft cervix in a case of early pregnancy. Hagar sign, it is generally seen around 6 weeks, a soft isthmus. Osiander sign is pulsatility in the lateral fornices, and Goodell sign, that is a soft cervix. And Piscasex sign, now that is a irregular enlargement of the uterus. Irregular enlargement of the uterus, that is in the early pregnancy days. That is, if the uterus is having, let's say, the uterus has two corners. So when the uterus has two corners, we call them two cornus. And if the pregnancy implants, let's say, in this cornu, okay, in this, it's not a cornual pregnancy, it's just that the pregnancy is always implanted a little eccentric towards the side. So if it is, let's say, implanted in this part of the corner of the uterus, then initial few days, this part will be like that, and this part will increase in size. So there'll be a little irregular kind of an enlargement in the initial few days of pregnancy. That is what is called the Piscasex sign. Initial few weeks, there is irregular enlargement of the uterus. That's known as Piscasex sign. Later it becomes all fine. It becomes a normal, regularly enlarged uterus. Which part of the placenta is depicted in the picture below? See, I'm holding a placenta here on the back of my hand, and you must remember that whenever a placenta comes out after the delivery of the baby, when you do the placental delivery, you must always place the placenta on the back of your hand and then examine the placenta on the back of your hand. Why on the back of your hand? Because see, my hand is shaped like a dome. So the placenta is also attached on the uterus in this way. It's like a dome-shaped attachment. So keep the placenta at the back of your hand, and that's where you should be examining it. And when you're doing this, you'll see that there are multiple cotyledons here. So this is obviously the maternal surface. Okay, the fetal surface will have the umbilical cord attaching to it. So fetal surface will look something like this. Okay, there'll be a vein here and two arteries here. That'll be the fetal surface. So this is the maternal surface which we're showing you here. So now see, this is the one where we are showing you the fetal surface. But there is something wrong with this placenta. Guys, what's wrong with this placenta? What type of placenta is shown in this picture? So is it a normal placenta? Not a normal placenta. Is it a battledore placenta, a circumvallate placenta, or a succensurate placenta? So yes, this is a battledore placenta. See, the placental cord, which should be attached somewhere here in the center of the placenta, the umbilical cord, which should be attached here somewhere, is not attached there. It is attached somewhere here at the margin of the placenta. So this is also known as the marginal insertion. It is also known as a marginal insertion of the placenta, and this is the one in which there can be the detachment of the cord. When I'm doing a controlled contraction and trying to take out the placenta, there might be a detachment of the cord. All right, so that is the answer to this one. Answer is B. Now, what is the circumvallate placenta? Circumvallate placenta is this picture here. You can see that the chorion is a little small. The chorion or the placenta, I have told you this many times. Chorion is same as the placenta, which is same as the chorion. All right. So if the chorion is small, if the placenta is small, and the membranes are the normal size, so the membranes get folded on the periphery of the placenta. So doubled up membranes you'll see. So this is what is happening here. See the doubled up membranes here. You can all appreciate here. These are the doubled up membranes. So this is what is known as the circumvallate placenta. It is associated. I don't know whether you can see the yellow color. It is associated with preterm labor, intrauterine growth restriction. PTL is for preterm labor, intrauterine growth restriction, but very importantly, abruptio placentae. Abruption, and that is the MCI question, all right? Abruption, this is where they are asking you. M for MCI question. So they've asked you this many times. What is the common relation of a circumvallate placenta with which obstetrical problem, which is the abruption? All right, guys. So let us see this one now. What type of placenta is here? You can see that I'll give you a hint here. You have a nice big placenta here, and then there's another small bit of placenta which you may neglect when you're doing a delivery. Yes, you got the hint. Yes, this is a succenturiate. It's a succenturiate lobe. Succenturiate lobe or the accessory lobe. And yes, when you take out the placenta, this small lobe may stay back inside and present like a retained bit of placenta. What does that present with? Retained bit of placenta, what does it present with? Secondary PPH. Yes. And what's the management of secondary PPH? Yes. A curettage. Secondary PPH is because of retained bit of placenta, and that is managed with a curettage. And the complication of that curettage, maybe not every time, the complication of that curettage is a Asherman syndrome. All right, guys, let's see another one. This is the same picture here again, which I'm showing you nicely, the succenturiate lobe. Okay, so earliest sign of pregnancy on ultrasound. Earliest, that's a small grammatical mistake here. Earliest sign of the pregnancy on ultrasound. So first thing you will always see, yes, first thing you'll always see is a gestational sac, and next you're going to see, along with the gestation sac, you'll see a yolk sac, and next to the yolk sac you're going to now see the fetus developing. We call it a fetal node. Okay, so this is a fetal node, and this is the yolk sac, and this next will show us a cardiac activity in the fetal node. Okay, so what is the first sign? The gestational sac. Gestational sac, yolk sac, fetal node, cardiac activity. That's the stage of progress of the fetal development. What is the first method by which you can document a fetal heart rate? Yes, transvaginal sonography. All right, so let's move on. Earliest sign is a gestational sac. D is the answer here. A 28-year-old pregnant woman at 34 weeks of gestation presents for a routine prenatal visit but has decreased fetal movements over the last 2 days. Which of the following is the next appropriate initial test to assess the fetal well-being? Yes. So we'll always say that is your baby moving properly whenever a pregnant lady comes around 32, 34 weeks. Now the patient says, no, the baby is not moving properly. So yes, it could be a sick baby, but it could be a baby who's just sleeping and not moving much. So never say a loss of fetal movement. Do not take it very lightly. Never say it's nothing. Always do a NST first. Loss of fetal movements, always do an NST, and best time to do an NST is after a meal. So give her a good breakfast and do the NST, or a good lunch and do the NST. So when you do this non-stress test, that is the first initial test. So in a non-stress test, you know that if the fetal heart rate, let's say baseline is 120 and it can go up to 160, that's the normal range of the fetal heart rate. And if the heart rate is, let's say, at 130 and it is like going like that, tuck 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 tuck, and then there is a fetal movement here. So with the fetal movement, the heart rate should increase at least 15 beats, and then it should increase by at least 15 beats from the baseline, and it should last for at least 15 seconds, and this should happen at least twice. So there's a fetal movement again, 1 and 2. Two fetal movements have happened. This should happen at least twice in a 20-minute study. Alright, see, it has gone from 130 to almost 150 here. So increase in the baseline by more than 15 beats, lasting for more than 15 seconds, and happening at least twice in a 20-minute observation study. That is what is a reactive non-stress test, and that is almost always the first thing we do when a woman comes with reduced fetal movements. All right. So in NST, how many probes are there on the tummy? That's the next question. When the mother is lying down, they'll show you a picture with one probe, which is the Doppler for the heart rate. That is non-stress test. But if there are two belts on the maternal abdomen, if there are two belts, then think in terms of a cardiotocography. Okay, two belts means there is a association seen with the uterine contraction. We see the fetal heart rate. So with the uterine contraction, what happens to the fetal heart rate? That's what is seen in a cardiotocography. Okay, there are two belts in a cardiotocography, which is done in labor cardiotocography. All right, guys. Which of the following is an absolute contraindication to an IUCD insertion? I'm going to give you some time. You know, this test is not given to you live. Because I know that you guys are all having multiple revision sessions by multiple sources, and I don't know when to catch you for a live session. So I've recorded this and see this on your. I've giving you this over the weekend. So see this on your leisure and answer them. I'll be answering on the chat. I'll be regularly seeing the chat throughout the day till your exams are over, and keep answering your queries if you want. You can keep asking me queries on the chat. So yes, what is an absolute contraindication to an IUCD here? Unexplained vaginal bleeding, history of previous PID, previous ectopic pregnancy, HIV positive status. Guys, HIV positive is never a contraindication. Okay, you can give an IUCD for a contraception. If the couple is HIV positive, they can have intercourse, isn't it? If the couple is HIV positive, then they can have an IUCD as a contraception. But if only the man is HIV positive and the woman is negative, then the man wears a condom and has intercourse with this woman, and she can still have an IUCD. If a woman is a HIV positive, she can still keep an IUCD. IUCD is not going to change anything with the HIV status. IUCD is not going to increase the chances of infection in HIV positive woman. Yes, if she's got AIDS, then of course anything will be a problem, isn't it? She's got just an HIV positive status, then it is not a contraindication. Previous ectopic pregnancy is not a contraindication, guys. Now this is where you guys are wrong. You keep thinking that an IUCD increases ectopic pregnancies. No, IUCDs reduce pregnancies, and that's why IUCDs actually reduce ectopic pregnancies. So if a woman gets pregnant while she's on IUCD, there's a relative increase in the ectopic pregnancy, not an absolute increase in the number of ectopics. So never say IUCDs increase ectopic pregnancies. IUCDs actually reduce pregnancies, and they actually reduce the ectopics. So that's why an ectopic pregnancy previously is not a contraindication for giving an IUCD if she wants now. Yes, I know there's a controversy in this. Many people have been telling you a different answer. Please, I'll show you some proof. Okay, so history of previous PID, yes, it is not a contraindication. Present PID is a contraindication. So yes, absolute contraindication is unexplained vaginal bleeding. If she's got irregular vaginal bleeding, unexplained vaginal bleeding, till you sort out that, do not put an IUCD. Because what is the most common complication of an IUCD? Excessive bleeding. You know that, isn't it? So answer is A. Now let me show you some. So what is this MEC1 and the MEC2, MEC3, MEC4? So medical eligibility criteria of a contraceptive device. That is, there is 1 and 2 means if a person, let's say, is having a HIV status positive, and the mother wants to use an IUCD, then HIV status is not a contraindication. So what is HIV status positive in relation to IUCD usage in MEC terms, medical eligibility criteria terms? So then it is MEC1. If a woman is HIV status positive, she wants to use an IUCD, then it's a MEC1 status. It is not a contraindication. Suppose they say woman is having active vaginal bleeding and she's got an infection. Can she take an IUCD? That is MEC4. Medical eligibility criteria 4. She's got an infection. If you put an IUCD, it will flare up the infection. So cannot use. So MEC1 to MEC4 are the criteria which are governing all the contraceptive devices. All right. MEC1 and 2 means you can use. MEC3 and 4 you cannot use. Okay. More or less, that is correct. So when you're talking about IUCD, I'm trying to tell you the MEC status regarding your previous ectopic discussion which we are having. Okay. So yes, if you see here, if a patient has a PID current, then initiation of an IUCD is MEC status 4. It is a contraindication. All right. Past PID, just now we discussed, is MEC status 1. It is not a contraindication. All right. I'll try to show you the next question now. A 28-year-old nulliparous woman presents with severe lower abdominal pain and a history of blackouts. She has amenorrhea for the last 8 weeks. An ultrasound confirms a ruptured ectopic pregnancy with significant intra-abdominal bleeding. Blood pressure is 80/50 and pulse rate is 120. That is, she's getting into shock. And which of the following surgical procedure is the most appropriate for this patient? So, ruptured ectopic pregnancy in shock. Okay. So, first of all, remember the clinical triad. There are three things in the clinical triad of a ectopic pregnancy: pain abdomen, vaginal bleeding, and history of amenorrhea. This is the clinical triad. This is what the history the patient will give you. Of course, the same history is given in abortion also, but if the patient has shock along with these three, we are thinking of a ruptured ectopic pregnancy. This is a ruptured ectopic pregnancy. Any emergency, you know that we have to do the resuscitation. So along with the resuscitation, what is the most appropriate management? So we are talking about the obstetric management of a ruptured ectopic pregnancy here. So laparotomy and repair, never repair a ruptured tube. Okay, never repair a ruptured tube. Laparotomy and resection and anastomosis of the tube, no, you do not reanastomose a ruptured tube. The tube is blasted. It is, the all the layers of the tubal epithelium, so the circular layer and the longitudinal layer of the muscles and the serosa, everything has been eroded and the tube has ruptured. So it's a destroyed tube. We are not repairing it. I don't know where you're getting this information from. Never repair a ruptured tube. Never do a resection anastomosis. Laparotomy with a total salpingectomy, laparotomy with a partial salpingectomy. What is the choice? It's always total salpingectomy. If the tube is ruptured, we all understand that if a tube is ruptured, then it is worth only the dustbin, nothing else. So you're going to put a clamp here, you're going to put a clamp here and throw the tube in the dustbin. There is nothing called a partial salpingectomy, and if somebody is doing it, that person is going to get sued. Sooner or later, people in our country also are going to realize that if I had an ectopic, then why did the doctor not do a complete removal of that injured tube? Because she may have a repeat ectopic because of that small stump which you're going to leave with a partial salpingostomy. All right, so total salpingectomy, partial salpingectomy, I meant, and a total salpingectomy we have to do. So no partial salpingectomy, you have to do a total salpingectomy. All right, guys. So see, this is a case of a ruptured ectopic. Let me show you what's happening here. See this? This is a ruptured tube, and there is so much of blood that you can barely see anything in this film. Yes, now you see the uterus, and I'm putting a sponge holder, a laparoscopic procedure I'm doing in this rupture. And in this, I have gone in. Now I'm holding the tube, and I'm going to pick up. See, where is this? It's in the ampulla again. Huh? Don't say it's in the isthmus. Most common site of an ectopic is the ampulla. See, this is a ruptured ampulla, and it is bleeding through that. And what am I going to do? I'm going to put a clamp here. And what am I going to do with the ruptured tube? Yes, guys, I'm going to go ahead and do a total salpingectomy. See this next video here, we are going to show you a total salpingectomy. All right. Here, we are going to give a traction to the tube. And look, we are not doing anything to the ovary, please. We do total salpingectomy, not a salpingo-oophorectomy. See, the tube has been removed and the ovary has been conserved. Okay, so total salpingectomy for a ruptured tube. So for the unruptured ectopic pregnancy, we can try and save the tube because especially if a woman is not having any children. So we can try to save the tube. We can do it by medical methods or we can do by surgical methods. And surgically, what we have to do, we have to make an incision on the fallopian tube, the bulge. Suppose it's in the ampulla, make a lengthwise incision on the bulge of the tube, and we just with the incision take the baby out, and along the incision we do a cautery and stop the bleeding. Linear salpingostomy, like showed here, is the best surgical method. or you can also do a resection anastomosis. Here you can do a resection anastomosis because it's an unruptured tube. You're doing a surgical cut of the tube and a repair. So that has got a very good prognosis, a resection anastomosis in a unruptured tube, but not in a ruptured tube. And methotrexate can be given as a medical management. Methotrexate will degenerate the pregnancy and the immune system will absorb the baby over time. So how do you decide this? It is decided based on some criteria. So if there is a size of the ectopic pregnancy is 4 centimeters, and if the HCG is 5,000 international units, and the cardiac activity, so if the cardiac activity is present, we do surgical management, and negative, then we do medical management. And if the HCG is more than 5,000 or less than 5,000, more than 5,000 we do surgical management, less than 5,000 we do medical management. And if the size is more than 4 centimeters, we do surgical management. If it is less than 4 centimeters, then we do a medical management. These are the criteria. So anything which is towards the right side will prompt us to do a surgical management. Okay. Induction of labor can be done in which of the following conditions? So induction of labor cannot be done for a plasma previa. Plasma is covering the os. Previous classical cesarean section can never have a induction of labor because the chance of rupture, if I give a labor, the chance of rupture in a previous classical cesarean section is 8 to 10%. Vasa previa, again we cannot do. You know, in Vasa previa, it is a velamentous cord. It is a placenta which is here, the baby which is here, the placenta is attached in the upper segment like it should, the cord is going like this, but after some distance the umbilical cord loses the Wharton's jelly. That means there is no cover, there is no cover to the blood vessels which are going to the placenta. So this is a velamentous cord. But if the velamentous cord is in front of the os like this, if it is in front of the os like this, then this cord can break when the baby is delivering or when the baby moves. So when these vessels break, then the baby bleeds. So this is a vasa previa. Again, you cannot do a normal delivery in the case of a vasa previa. So yes, abruptio placentae, you can do a normal delivery. Please, abruptio placentae associated with hypertension most commonly is by itself not an indication of a cesarean section. Abruption means try and commit to a delivery. Don't conserve in an abruption because that will cause DIC. In a placenta previa, you can conserve. If it is before 34 weeks, you can conserve a placenta previa. But in abruption, we never conserve because DIC can happen. Yes, guys, you have read. Very good. In abruption, we don't conserve. In abruption, we deliver. How do we deliver? We do an ARM, start oxytocin, and that will enhance the chances of a normal delivery. Of course, with an abruption, if there's a fetal distress, go ahead and do a cesarean section for fetal indications. There can be metal indications also. If she's losing too much blood and if she's getting hemodynamically unstable, then we'll have to go ahead and do a cesarean section. Otherwise, abruption by itself is not an indication of a cesarean section. Okay. Just after delivery, the position of the uterus corresponds to how many weeks of the uterine size. So immediately after delivery, the uterus is just below the umbilicus. It's an extremely important message because when the uterus is felt just below the umbilicus, this is the time, if it can be felt in the abdomen easily, then we can make a very simple incision on the abdomen, go inside the abdomen, get this tube and get this tube, and both the tubes can be ligated very easily because uterus is an abdominal organ for some time. So because of the fact that immediately after delivery the uterus is an abdominal organ, and especially if she delivered a second child today, tomorrow morning I can post it to the OT and do a very simple puerperal sterilization or a postpartum sterilization. So immediately after the delivery, the uterus is at the level of 20 weeks. When does the uterus become a pelvic organ? When does it become a pelvic organ? Please don't say 6 weeks. It becomes a pelvic organ in 2 weeks. When does it become a normal organ? It becomes a normal organ, guys, in 6 weeks. Okay. So it becomes a pelvic organ in 2 weeks and a normal organ in 6 weeks. That's why puerperal sterilization cannot be done till the end of puerperium, that is 6 weeks. Puerperal sterilization cannot be done till the end of 6 weeks. Puerperal sterilization or a postpartum sterilization is best done within the first 2-3 days. Maximum can be done for 7 to 10 days, because in 2 weeks the uterus becomes a pelvic organ. Then the surgery becomes difficult. All right. So the answer is 20 weeks. All are seen in the newborn of a mother with gestation diabetes mellitus, except now, guys, GDM, extremely important question which keeps coming in exam. GDM occurs after 24 weeks. Please, there's a lot of confusion about this. GDM occurs after 24 weeks. That's why screening for gestation diabetes mellitus is done after 24 weeks. What's the test? It is GTT with 75 grams of glucose. Fasting should be less than 92. 1 hour should be less than 180, and 2 hours should be less than 153. Any one abnormal value is diagnosis of GDM. That's the test which we're doing. So that's why GDM, when it happens after 24 weeks, how will it cause anomalies, guys? GDM cannot cause anomalies. Very important question. It has come in INICT twice. It's come in your NEET exam also. Please, GDM never causes anomalies. Pre-existing diabetes, if a woman is diabetic in the first trimester, 7, 8 weeks, 9 weeks, when organogenesis is happening, at that time, if she's got high sugars cause free radical injury, and when the organs are forming, that free radical injury causes anomalies. Please, first trimester high sugars, which is actually the pre-existing diabetes which is coming in pregnancy, that is the one which causes anomalies. GDM never causes anomalies. So the answer is neural tube defects. All right, guys. Diabetes screening pregnancy is the 75 grams glucose oral glucose tolerance test. So fasting should be less than 92. Then you give the 75 grams of glucose. 1 hour value should be less than 180, and 2 hour value should be less than 153. Less than, guys. If a person has a fasting of 92, I put her on a diet. Yes, less than 92 is normal. 92 is not normal. 92 is reason for us to put her on a diet. We do this regularly in the hospitals where we work. All right, any one abnormal value is diagnostic of GDM. Okay, guys, let's see the next question. Which of the following is not a germ cell tumor? We'll get into some. It's not a very good split between obs and gyne, but now I think we are going to have some more, gynecology questions. There might be some obstetrics coming up later in the discussion. So, which of the following is not a germ cell tumor? So, choriocarcinoma is a germ cell tumor. Granulosa cell tumor is not. Yolk sac tumor is a germ cell tumor. Dysgerminoma, of course, is the yolk sac. It's a germ cell tumor. So dysgerminoma is the most common germ cell malignancy. Yes, germ cell malignancy, which is the most common, it is the dysgerminoma. Yolk sac tumor is also known as an endodermal sinus tumor. And granulosa cell tumor is a sex cord tumor. Granulosa cell tumor is a sex cord tumor, like the Sertoli lady cell tumor. Okay, so granulosa cell tumor is a sex cord, and that tumor will make a lot of estrogens, and that lot of estrogens causes the young child to have precocious puberty, other women to have menorrhagia, and senior women, because of the granulosa cell tumor, which is making a lot of estrogens, they can also have hyperplasia of the endometrium and endometrial cancers. All right, guys. Germ cell tumors, this is the list which I've given you: dysgerminoma, yolk sac tumor, embryonal carcinoma, polyembryoma, then non-gestational choriocarcinoma, mixed germ cell tumor, and the dermoid tumor. So, in normal physiology of oogenesis, in which phase is the primary oocyte arrested? So, when a girl is born, she's born with something like 1 or 2 million pyramidal follicles, and out of that, she's left with around 3 or 4 lakhs pyramidal follicles at puberty from when she starts ovulating. So, these oocytes which are there, these 1 to 2 million oocytes, the primordial follicles which are present, they are arrested in the prophase of the first meiotic division. So yes, I know most of you would have answered prophase of the first meiotic division. And which part of the prophase? The diplotin. So the prophase, the first prophase, and in that the diplotin phase. So prophase 1 has leptotin, zygotin, pachotin, diplotin, and dikinesis, and the oocyte is arrested in the diplotin phase. And now when the girl becomes a pubertal girl and she starts ovulating, and that's when the ovulation resumes and it is reaching the metaphase 2 stage. It goes up to the second meiotic division till the metaphase of the second meiotic division. The metaphase 2 oocyte is the one which is released. So metaphase 2 oocyte is released when the ovulation happens. Now this metaphase 2 oocyte has one polar body. So when is that one polar body released? The M2 oocyte, like we call in our IVF terms, the metaphase 2 oocyte which is released has one polar body, and this polar body is released just at the time of ovulation. At the time of ovulation, or second choice, just before the ovulation. So if they ask you when is the first polar body released, at the time of ovulation. When is the second polar body released? After the fertilization by the sperm. Okay, so the oocyte is resting twice. Once in the time when the girl was born, at that time it is resting at the prophase of the first meiotic division. Then after ovulation it is resting again till it is fertilized. So it is resting in the metaphase 2, the second meiotic division, the metaphase 2, and then it resumes after it is fertilized by the sperm and the second polar body is released. Right, guys, let's move on. Which of the following is the smallest diameter of the female pelvis? So at the inlet, okay, I think I should have written that. At the inlet, what is the smallest diameter? So at the inlet, all the choices are suggesting the inlet, okay. Mid pelvis, I'll give the answer. Mid pelvis, the narrowest diameter is the bispinous diameter, okay. So at the inlet, what is the narrowest diameter? So obviously the diameter of obstetric importance will be the shortest. So the obstetric conjugate is the shortest diameter. Let me show that to you with a diagram properly here. So if you see the head which has to enter the pelvis, the diameter of engagement is the suboccipitopragmatic diameter, which is 9.5 centimeters, and has to come out in delivery like this. So when you see this, what are the inlet diameters which are going to be of importance here? So see, from the back of the pelvic symphysis, if you see, there's a red diameter which is going like that. That is the obstetric conjugate, that is of obstetric importance, because that's the shortest diameter, the red one, because from the back of the pubic symphysis there is a pubic prominence. So from this pubic prominence to the tip of the sacrum, that is the obstetric conjugate, and the green one is known as the true. It is known as the true or the anatomical conjugate, okay, and the blue one is known as the diagonal conjugate. Now in the OPD we can only measure the diagonal conjugate by a per vaginal examination. With the obstetrician fingers we measure the uh, diagonal conjugate, and mostly it is around 12 centimeters. So the true or the anatomical conjugate is diagonal conjugate minus 1 centimeter, that is around 11 centimeters, and the obstetric conjugate is diagonal conjugate minus 2 centimeters, that is around 10 centimeters. So yes, the obstetric conjugate is derived by subtracting 2 out of the diagonal conjugate, and generally it's 10 centimeters. So how much is the suboccipitopragmatic diameter which is entering the pelvis? That is 9.5. And how much is the obstetric conjugate? That is 10 centimeters. So in this pelvis, where the obstetric conjugate is 10 centimeters, the head of the baby can easily enter inside. So that is what is known as the uh, diameters of the inlet. All right, let's move on to the next one. Instrumental delivery is indicated in all of the following cases except. So maternal exhaustion is one of the major indications, and the next one is definitely fetal distress. These are the two short indications of putting a instrument for, that is forceps or vacuum, for the early delivery of the fetus. But cephalopelvic disproportion is not. Prolonged second stage of labor, again we can do forceps or vacuum. But CPD, that means the head of the baby is big for this pelvis. So forget putting an instrument. The head itself cannot go through this pelvis. And if you try to put an instrument, you're occupying more space. And then you pull the head out of this small pelvis, you're going to cause a sudden injury to the head. You're not going to cause that sudden compression like this. And when the baby is born, he'll have intraventricular hemorrhages. So please, you're going to cause a lot of injuries to the baby. You're going to cause a lot of injuries to the mother's pelvis and the mother's vaginal muscles and the vaginal mucosa. She'll be having torrential bleeding. Please, cephalopelvic disproportion, if you've diagnosed, don't go and say that the answer is instrumentation. CPD, the answer is cesarean section. All right, guys, let's. So, what is early onset eclampsia defined as? So, we know that along with hypertension, if there is proteinuria, we call it preeclampsia, and with preeclampsia, if there is a convulsion, we call it a eclampsia. So, when a person has convulsion, that is eclampsia, mostly it is around 37, 38 weeks. Can also happen in labor. but sometimes the disease progression is so fast that this conversion can happen even before 34 weeks of gestation. So that's when it is called a early onset eclampsia. So let's do a quick revision. Gestational hypertension is blood pressure more than 140/90, which is after 20 weeks of gestation. Along with that, if there is proteinuria, we call it a preeclampsia. How much protein is proteinuria? More than 300 milligrams of protein in 24-hour urine, which is also called 0.3 grams. And eclampsia is, along with that, if there is a convulsion. Okay, along with that, if there is a, along with this what I wrote above, if there is a convulsion, it is known as a eclampsia. Now please do not confuse epilepsy with eclampsia. Epilepsy is a neurological disorder, let's say a intracerebral space occupying lesion or an injury to the head or a metabolic problem causing convulsion. That is epilepsy. And epilepsy drug of choice is lamotrigine, okay, or levetiracetam. We are not talking epilepsy right now. We are talking about eclampsia, which is hypertension and a convulsion. So when a person has hypertension convulsion, that is what is known as eclampsia. So what are the signs of imminent eclampsia? Nausea, vomiting, headache, blurring of vision, and a blood pressure more than 110 diastolic. Also exaggerated knee jerks. And what is the management of eclampsia? When a person has eclampsia, give a magnesium sulfate. Along with that, give a levodopa for the blood pressure and terminate the pregnancy. Once eclampsia happens, that's the worst case scenario which can happen. Once eclampsia happens, go ahead and terminate the pregnancy. Now the next question, what is the management of a impending eclampsia, imminent eclampsia? That is, she's about to throw a convulsion. She has all of these signs: nausea, vomiting, headache, blurring of vision, exaggerate knee jerks, all those. Along with that, if the patient convulses, we say it's eclampsia. So before the convulsion, we call it stage of impending or imminent eclampsia. So what is the management of impending eclampsia? Just the same. She is reaching the worst case scenario, so the management is just the same. Okay, so both of these conditions, the management is, yes, the management is magnesium sulfate, levodopa, and terminate the pregnancy. Termination of pregnancy is the most definitive management of eclampsia. Many times this question has come in a NEET exam. Termination of pregnancy is the most definitive management of eclampsia. Take out the baby, the blood pressure gets to normal in next 1 week in 90% of patients. All right. A female presented with complaints of foul smelling vaginal discharge. Whiff test showed positive results. Which of the following is the causative organism associated with this? Whiff test is classical of bacterial vaginosis, and bacterial vaginosis, trichomoniasis. Homework for you guys today. If you've not read them, please go ahead and see the charts which I've given you. Trichomoniasis, candidiasis, and bacterial vaginosis, all three I've compared in all the notes wherever I've given you. So please compare these three together and remember them in detail. So this is bacterial vaginosis whiff test. To the secretions, if we add potassium hydroxide, it's going to release ammonical odor, ammonical whiff. That is what is known as a whiff test. So this is seen in Gardnerella vaginalis, also called Haemophilus vaginalis, which causes bacterial vaginosis. And in bacterial vaginosis, you must also remember we see clue cells. Okay, so the answer is Gardnerella vaginalis. Okay, so these are the clue cells of bacterial vaginosis, clue cells. The vaginal epithelial cells with embedded bacteria. These are known as clue cells. And what is more important? There are clue cells in the vagina, but there is absence of leukocytes in the vagina because of the bacterial vaginosis. Which among the following is the most common cause of postmenopausal bleeding? Now, this is a hot shot topic. Postmenopausal bleeding, what is the most common cause? And these are the choices. There's endometrial atrophy, and there is C. endometrium, C. cervix, and endometrial polyps. A lot of confusion is there about this, but if you, all you interns who are looking at this presentation, you would actually have more clarity. Yes, some of our MCI students have not worked or have done the internship, and for the first time they're getting exposed to the clinical side. So with them, if there are some mistakes, I can understand, but the interns who have worked in Indian institutes, I want you to give me the right answer. Tell me, what have you seen in your OPDs? Have you ever even seen a case of endometrial atrophy or senile endometritis? Tell me even if one case you've seen. And each one of you, all you interns and post-intern, put a hand on your heart and tell me that each one of you would have seen a case of CS cervix, because it is rampant in our country. all of you have seen CS cervices, but most of you, I'm sure, actually none of you have seen senile endometritis. So please don't answer that. Okay. So endometrial atrophy can get infections easily. It is known as senile endometritis. So why does this become an answer sometimes in the exams? In some sources, you must have seen this answer as senile endometritis. So let me explain this to you in detail. Because this is a Western data, and all the good books like my Novak's Gynecology, Shaw's Gynecology, there's a Williams Gynecology also, all the major gyne books of the world, which are Western books, they are giving senile endometritis, which is a complication of endometrial atrophy. They're giving this as the most common cause of postmenopausal bleeding because these are Western people, Western data. They hardly have CS cervix as compared to our country. We already have 2 lakh cases of CS cervix this year in our country. So please remember, Western data says endometrial atrophy. So let me show that to you with proof so that from here on you'll never have a doubt. Okay, see this. Causes of postmenopausal bleeding. This is a Western data. This is from Novak's Gynecology. This is Novak's. Yes, I've written here 16th edition. So the most common cause, 60 to 80% of the cases, it is endometrial atrophy in the West. After that, there is hormone replacement therapy, almost 25-30%. Endometrial polyps, 2 to 12%. Endometrial hyperplasia, endometrial cancer, cumulative around 20%. Is there even CS service mentioned in these cases? No, because in the West, CS service has been majorly controlled because of lifestyle modifications, early screening programs. So it's been majorly controlled. We are also controlling it majorly in a country, but we still have rampant CS cervix. So in the West, it is endometrial atrophy, and they are not going to ask you Western figures. Okay, if at all these 5 choices come and they've not given CS service, go ahead and mark endometrial atrophy. I mean, somebody just picks up a question, picks up a page from Novak's and gives you a question without thinking for that moment that I should be asking you Indian data. Somebody does a mistake, they can ask you Western data. Go ahead and mark senile endometritis or endometrial atrophy. You're free from my side to go ahead and do that. But if CS service is given, that is the answer for you guys. Now let me show you some Indian data. This is Western data. Let me show you some Indian data. Now, this is the Indian data. It is one of the later studies which have come out. This is 2022. This is an Indian study about postmenopausal bleeding. And look at the causes. I'm going to show you. I'm going to enlarge this. The one I have highlighted in red. I'm going to enlarge this and show you the results. Okay. Histopathology in cases of postmenopausal bleeding, histopathology examination was suggestive of atrophic endometrium, that is endometrial atrophy or the senile endometritis, which you keep saying, is 2.3%. Then endometrial hyperplasia is 6.4%. C endometrium is 12.2%. Proliferative endometrium 9.4%. Endometrial polyps 2.9% only. And CA cervix, guys. CA cervix is 39.5%. Indian data, guys. See this now. Postmenopausal bleeding. What is the histopathological result? It is CA cervix. 39.5. There is no comparison also with the other causes. So you're Indians, we are going to ask you Indian data in the NEET PG exams and the MCA exam. And if CA service is given there, go ahead and bindas mark CA cervix. Yes, of course, if senile endometritis or endometrial atrophy is given and CA cervix is not there because of some misfortune, somebody didn't think before making a question, can happen. Then go ahead and mark senile senile endometritis or endometrial atrophy. All right, guys, let's move on and see some other things. Okay, now post-menopause bleeding, I want to just tell you a few more things. Okay, most common presentation of CS cervix. What is that? That is post-coital bleeding. What is the most common presentation of CA endometrium? It is irregular acyclic bleeding. Most common presentation of CA cervix and CA endometrium. Mind you, CA cervix is the commoner cancer in India versus CA endometrium. Now, CA cervix may also have post-menopausal bleeding. CA endometrium also may have post-menopausal bleeding. Okay, so I taught you just now what are the causes of postmenopausal bleeding. Now, what is the presentation of C cervix, postcoital bleeding, and postmenopausal bleeding? What is the presentation of C endometrium, irregular acyclic bleeding, and also postmenopausal? Now, which of the following is not a quadruple test marker? That is, we do the quadruple test around 16th week onwards in pregnancy for predicting, chromosomal defects and genetic defects. We do this chromosomal assessment and genetic assessment. These are not diagnostic, but these are good screening tests. So quadruple test is having four variables. So one of them is unconjugated estriol, E3, and here they've written estradiol. So this is wrong. It is unconjugated estriol. This is IUCD question last year's, okay? And they wrote estradiol, and most people got confused. So it is unconjugated estriol. So this is the answer here. Yes, it has alpha fetoprotein, it has beta HCG, and it has inhibin. So it is inhibin A, dimeric inhibin A. So yes, you know that alpha fetoprotein, unconjugated estriol, they will reduce from the normal values, HCG will increase from the normal values, and dimeric inhibin A will also increase from the normal values. Okay, so we can remember it by H. H always stays high. H is high means it is bad news. And IN for inhibin. Inhibin also stays high. Okay, so H for high and IN, inhibin, for increase. So these two are high and the other two are lower. So that is what is going to give us the quadruple test. Then mitochondria in the sperms is seen in which area? NEET exam question. It is in the head, cap, midpiece, or the tail. So the head has the nucleus of the sperm, and the midpiece has the mitochondria. All right, so mitochondria is in the midpiece. Okay, that's the picture here. You can see the mitochondria is here in the midpiece. Alright guys, so what is the single best parameter of semen analysis? It's always morphology, and don't say motility, okay? Morphology is the single best criteria of the semen parameters, and it is 4% or more should be normal semen morphology. Count should be 39 million, okay? 2021 WHO values of semen you should be reading. Okay, so 2020 values are, sorry, 2010 values are outdated, 2021 values are asked. And morphology, total count, and the pus cells, these are still the same. Other parameters have changed. All right, chalo. A 46-year-old woman presents with irregular acyclic bleeding for 3 months. An endometrial biopsy shows simple endometrial hyperplasia without atypia. So what is the management? Yes, what are you going to do? So this is that hot shot PG entrance and NCI question. If a woman has irregular acyclic bleeding and around 40 to 50 they're going to give the age, first thing, always examine the woman, rule out vulval, vaginal, cervical lesions. If there is no vulval, vaginal or cervical lesions, then you have to find out what is wrong with the endometrium. So in the OPD you can do a biopsy, a office endometrial biopsy. You can take her to the OT and do a DNC, or you can do a hysteroscopy in the OT. So these three procedures are the ones which you should answer. Okay, so first is the office endometrial biopsy, or then you can do a DNC in the OT, or you can do a hysteroscopic biopsy. So these are the three methods by which you can get, and the best assessment by a hysteroscopic biopsy. So when a woman has irregular bleeding, examine her first and do a office biopsy or a DNC or a hysteroscopic biopsy. Then if you get a result of endometrial hyperplasia without atypia or with atypia, this is just hyperplasia. So without atypia, the chance of cancer is 1% to 3%, and with atypia, the chance is 8% to 29%. Okay, so without atypia, the answer here, the answer here is a progesterone therapy, because estrogen causes hyperplasia, progesterone will cause secretion and stabilization of the glands, which we keep telling you so many times, and that is used for the treatment of simple hyperplasia without atypia. Of course, if it is with atypia, then you can do a hysterectomy. With atypia, the chance of cancer becomes 8 to 29%. All right, guys, so that is the answer. Let's move on and see what is the lesion shown in this vulva. You can see a swelling here at the area of the Bartholin gland. So this is a Bartholin cyst or a Bartholin's abscess. Okay, so Bartholin cyst, if it is there, it's a much lesser painful condition. We can put a catheter inside the cyst and slowly it keeps draining. We call it the words catheter. The words catheter can be put and it keeps draining, and slowly the bathroom gland will get emptied over a few days, and then they'll that punctum through which we put the drain, that will make the hole for the secretions to keep coming out. So that's how it is manage a bathroom cyst. But if the bathroom abscess, it's an emergency, so then you have to do a marsupialization, which you know very well. Bathroom abscess, marsupialization basically means exteriorization of the cavity. If suppose this is the bathroom abscess, you make an incision and keep it open. This is known as a incision and drainage. But if you everted the edges of the bathroom abscess and tied them to the vulval margins, so then it is going to cause the eversion of the cavity. The cavity is exposed. That is what is known as marsupialization. Okay, that's the treatment of a Bartholin's abscess. What type of fibroid is pointed in the image below? So yes, this you should know, the FIGO classification of fibroids, and the one which is pointed here is uh, the A here. All right, don't go by the A, C, B, D, and all that. You know, there might be some confusion, so don't. That marking is not of any use. You just tell me this arrow. This arrow is pointing to which type of fibroid. So that is a subserosal fibroid, but we call it a type 7 here. This is a type 7 fibroid here. This is more. This is more in the serosa and less in the muscle. This is type 6. Okay, and this one is a type 0, the one which is hanging here. All right, so you have to know these fibroids, the classification by FIGO. So this is the subserosal fibroid which I've shown you here. See a picture of a subserosal fibroid here. Can you see this peduncle here, this stalk here? This patient came with a mild torsion of the fibroid. She came with acute pain abdomen, and first time she came to me, and this is an emergency hysterectomy we did, because this patient was around 44-45 years. She had a pedunculated fibroid, and this pedunculated fibroid came with a mild torsion. So rather than doing a mammectomy, she was a multiparous lady and she was around 44-45. Forgot the exact age. We went ahead and did her. She had multiple fibroids. So this is that type 7 fibroid, subserous fibroid. Right. She will underwent in vitro fertilization, and she was given injection HCG for ovulation trigger, and now presents with nausea, vomiting, and headache. The ultrasound of the pelvis done shows some ascites, and ovary looks like the image below. You can see there are multiple follicles in this woman, which are all big. They're all big. Okay, so please do not confuse with PCOS. PCOS does not have all follicles big. There are multiple small follicles in PCOS. So there are multiple small follicles in PCOS. That's why in PCOS you don't see this picture. But when all these follicles are big, they're all dominant. That means this is ovarian hyperstimulation syndrome. So when both the ovaries put together, if there are more than 20 dominant follicles, that's what is ovarian hyperstimulation syndrome. Each follicle makes around 200 picograms of estradiol. That means 20 will make 4,000 picograms of estradiol, and more than 3,500 picograms of estradiol causes increase in vascular permeability. All right, and all the fluids from the blood vessels will keep going out. So yes, the answer is ovarian hyperstimulation syndrome. So let me show that pathology to you here, guys. So if you see this, that there is PCOS. Why did I write PCOS here? Because PCOS is more likely to have ovarian hyperstimulation syndrome. So let's say, for example, if you're stimulating a case of PCOS lady with injections FSH to get more dominant follicles for IVF, she's the most likely person who will have ovarian hyperstimulation syndrome. So see, all the ovarian follicles have become dominant, and that is what is going to give a lot of estrogen, especially if it is more than 3,500 picograms of estradiol. It is going to increase the vascular endothelial growth factor, and the HCG, which is given for the maturity of the eggs. That is the final culprit, which is going to increase the vascular endothelial growth factor. So estrogen along with the HCG increases the vascular endothelial growth factor because of the high estrogens. Okay, now this high vascular endothelial growth factor will increase the vascular permeability. So if you see the blood vessel here, the first picture, the fluids are moving out. See, the fluids are moving out. So in when the fluids are moving out, in the intravascular component there is hemoconcentration, and the third space there is ascites, pleural effusion, pericardial effusion, and edema happening. So this woman In the intravascular space, there will be hemoconcentration. Hemoconcentration can cause thick blood, can cause renal injury, cerebral injury, liver injury, heart injury, and cause multi-organ failure and even death. Then the ascites, pleural effusion, pericardial effusion can make the cardiac work and the breathing work difficult to happen, and the woman can have a death again because of this. And then the big ovary which is there, it can undergo torsion rupture and hemorrhage. So death can happen because of so many reasons, because of torsion rupture, hemorrhage, because of the hemoconcentration, and the third space, fluid accumulation. So that's what is the problem of ovarian hyperstimulation syndrome. Patient can be very critical or even can die because of ovarian hyperstimulation syndrome if you don't manage it too well. So what is the management of ovarian hyperstimulation syndrome? The management is to take out the fluids from the third space collection, that is ascites has to be tapped and the pleural effusion has to be tapped. But the intravascular component has hemoconcentration, which is causing end organ damage and also big organ damage like kidneys and the liver. So you have to increase the intravascular volume by giving oral fluids and IV fluids. And the best IV fluid which you can give is albumin, because albumin, in addition to replenishing the intravascular volume, will also hold the water molecules and prevent them from going out to the third space. So remove fluids and give fluids is the management of ovarian hyperstimulation syndrome. Let's see the next question. So a lady with infertility undergoes a laparoscopy for the purpose of assessment of pelvic anatomy. For tubal patency, a chromotubation involves pushing dye from a cannula into the cervix, which is observed to come out from the fallopian tube. Basically, that there's a uterus here, and in the uterus you're putting a cannula, the Leach-Wilkinson cannula, putting a dye, and the dye has to come out from the fallopian tube. So with the laparoscope I'm seeing over this, and if the dye comes out into the pelvis, we say the tube is open. So what is the color of this dye? What is the dye used for laparoscopy and chromoperturbation? So that is methylene blue, and don't say gentian violet, okay? And don't say urographene or iohexol. All of those are trade names of radiopaque dyes which are used for HSG. So the dye for HSG is a radiopaque iodine based dye, and the name for HSG dye is meglumine ditrizoate. Okay, meglumine ditrizoate. Okay, it is not urographene or iohexol, because those are trade names. You must remember the generic name. So for laparoscopy and chromotubation, it is methylene blue. That is the answer. So yes, we are doing a laparoscopy here, and while doing a laparoscopy, I'm trying to show you, this is around 4 years back, one of my patients where I'm doing laparoscopy, and my friend is putting the dye from below into the uterus, and see, the dye has come out from the left tube. If you're observant, you'll see from the right tube, see, now I'm showing you the right tube, no dye came out. So she had a unilateral block. So yes, around 3 years back rather, and this patient, we went on during the same procedure. I did a hysteroscopic cannulation of the right tube, and that right tube also opened, and she was fortunate enough to benefit from the surgery. She got pregnancy in the next 3 months, and she has a child now. So this is the case of a laparoscopy and a chromotubation with the methylene blue. Now, this is the hysterosalpingography. This is where we use the radiopaque dye, and that is meglumine ditrizoate. Pushing dye. All right, so I'm instructing in the OT how to go ahead and do this. So that is the meglumine ditrizoate, and you can see the uterus and the tube. Here, look here, you cannot see anything else but the tube and the uterus. Yeah, that's why we say it is a good preliminary test. It is not a very good definitive test for the assessment of the pelvic anatomy. Yes, just for tubal patency, we can say HSG, hysterosalpingography. But for the best assessment of the anatomy for an infertile woman, we always say laparoscopy and a hysteroscopy. All right, guys. So colposcopy, what is the color of the filter used? Now, most of you, those who attend my classes, are jumping on this question. I know you're going to say it is the blue filter or the green filter. Confused, right? Both can be used, but it's the green filter which is the answer, which is expected for you guys, because that's the choice which came in the exam 2 years back, and that was MCI exam. Okay, so yes, it is the green filter, although the blue also can be used. So yes, Colposcopic examination of cervix and the upper vagina with the magnification after application of 3 to 5% acetic acid using a white light and a green filter, can also be a blue filter. All right, so the magnification is 15 to 40 times magnification of the cervix. Okay, so minimal elements of a good colposcopic examination includes visualization of the squamous-columnar junction, identification of the estovite epithelium and the brown epithelium. Estovite is with acetic acid and brown is with the Lugol's iodine. Okay, this is with the acetic acid. It is like the name suggests, estovite, acetic acid, and brown is with the iodine, Lugol's iodine or the Schiller iodine also. And overall colposcopic impression should be there, what you assess with your colposcopy. Okay, 28-year-old para 1, live 1, presents with 20-week size uterus and a vesicular mole. What is your treatment? 20-week size is a big size uterus. And remember, the uterus is generally bigger than the pregnancy duration in the case of a vesicular mole. So whatever size they say, whatever size they try to impress with, once in AIMS exam, when it was AIMS exam, not the IUCD, they asked you what is the management of a 30-week size vesicular mole. So whatever size they want to, scare you with, never go and get confused and write a wrong answer. The answer is always suction evacuation. Whenever it is hydatopharm mole or vesicular mole, if they asked you, go ahead and write vesicular mole is evacuated by suction evacuation. Don't say DNC. This is where we don't say DNC. Most of the places in gyne you end up saying DNC and you can get away with it. But here you have to say suction evacuation under oxytocin infusion. Okay, so suction evacuation is the answer here. And of course, you must follow a vesicular mole for 1 year or at least for 6 months. HCG should be done in a weekly manner till serial HCG levels, like we say, till they come to negative. So in a vesicular mole, it takes something like complete vesicular mole, it takes something like 9 weeks to come to normal, and in a incomplete or a partial mole, it takes 7 weeks to come back to normal. Of the following grips of Leopold, which is the most informative about the fetal orientation, that is live presentation, engagement, etc. inside the uterus? So A, B, C, D. I hope you can see this. A, B, C, and D, which is the most informative. So the first one is putting your hands on the fundus of the uterus, and that is looking at the mother's face. The first, second, and the third grips are looking at the mother's face, and the third one is putting your hands above the pubic symphysis while looking at the mother's feet. So the first one tells us what is occupying the fundus, whether it is the breech or the head. A breech will be soft and irregular, head will be hard and round. What is occupying the fundus? Okay. Then the second one is a lateral grip. It tells me where is the back and where are the limbs. Third one is you put your hand above the pubic symphysis and see the lower uterus has a ballotable mass like a ball, then that is the head. If it is non-ballotable, then it is the breech in the lower segment. And the fourth one, this tells me whether it's the breech or it's the head. It tells me if it is engaged or not engaged. If it tells me that it's the head, it also informs me if the head is flexed, deflexed, or extended. So that's why the fourth maneuver is the most informative. Okay, D is the answer to this question. Most informative. In my exam, I remember in JIPMA days, we remember MBBS exams, there used to be one set question, and it was, Dr. Vij, please show us the grip which is going to give you all the information. Just one grip of the 4 Leopold maneuvers, and we are expected to go into the fourth maneuver. All right, so the third maneuver of the third Leopold grip, the third Leopold grip is also known as the first pelvic grip, and the fourth Leopold maneuver is also known as the second pelvic grip, and pelvic is also synonymously called pollic. Same here, it can be called a pollic grip also. All right, guys, so no confusions here. What is a reactive non-stress test? Yes, guys. So this is what we discussed in the beginning of the class, and now the definition. I hope you still remember it. Yes, 2 or more fetal heart accelerations of 15 beats or more persisting for at least 15 seconds in a 20-minute study. So B is the answer. Okay, this is the answer to this question. All right, I hope you remember that well. Move on to the next one. Identify this pattern on cardiotocography. So yes, when there are two probes, that is one which is seeing the uterine contraction and the other one which is seeing the fetal heart rate, then that is known as cardiotocography. And in cardiotocography, if the peak of the contraction coinciding with the lowest heart rate, that is what is known as a type 1 or the early deceleration, and type 2 is the one where the peak is not coinciding, it is a late deceleration, type 2. And then there is a variable deceleration. Okay, it might be more or less like that. So variable deceleration is because of the umbilical cord compression. It is because of the umbilical cord compression. So type 1 is because of the head compression. It is because the head compression during the active phase of labor. So with the active phase of labor, when there are good regular uterine contraction, the compression of the head causes deceleration. Mind you, I'm not saying distress. It causes deceleration, drop of 15 beats of the baseline. So if it is coinciding, it is early deceleration because of head compression. If it is not coinciding, like type 2 deceleration, it is seen in placental insufficiency. It is seen in placental insufficiency. All right. And third one, it is the cord compression. Umbilical cord compression causes the variable deceleration. This is the most common deceleration. Variable deceleration is the most common deceleration and is mostly normal. Which is the safest deceleration? Early deceleration because of head compression, which is seen in active labor. And which is not normal, the late deceleration because of placental insufficiency. And the variable deceleration, which is because of umbilical cord compression, is the commonest deceleration, and it is mostly normal. All right, so what is this one? You can see here the uterus has contracted like this and the fetal heart rate has gone down, but it is not coinciding. This is a late deceleration. So I'll give you some information, bulk information here now. The following set of instruments, what are they used for? Let's see. So this is a Hulka clip, the Filshire clip, and the fallopian ring. So what are they used for? Yes, these are used for a permanent sterilization of a lady, and this is the purpose of laparoscopic sterilization surgeries. Okay, what is the site of application of the concerned organ? What is the site of application on the fallopian tube? So yes, you apply on the isthmic area of the fallopian tube, always the isthmus. Why the isthmus? Because once you cut at the isthmus, isthmus has a uniform diameter. So when you cut at the isthmus, later if the woman wants to reanastomose her tube because she's lost her children or she has, remarried or something like that, then if the cut ends are uniform like this, then the reanastomose success is best. So that's why we do the sterilization at the isthmic level. So what is the most common wrong ligated structure while doing the procedure? So while doing a tubectomy, the most common wrong ligated structure is the round ligament. All right, always say the round ligament is the most commonly ligated structure. But please do not say the ureter. Ureter is not even in the abdomen. Ureter is a retroperitoneal structure. Don't say ureter is the most common wrong ligated structure. All right. Which of these has the best reanastomosis success? So these three, including all the other, I'm asking you, including all the other procedures like Pomeroy, modified Pomeroy is the most common tubectomy done still in our country. Laparoscopic clips, laparoscopic rings is also done. The fallopian ring and the Filshire clip or the Hulka clip, they're also done a lot. But the most common tubectomy done in our country is the Pomeroy's modified tubectomy. So of all the tubectomies, which has the best reanastomosis success? So that is the laparoscopic clips, whether it is the Filshire clip or the Hulka clip, both are the ones which are going to give us the best reanastomosis success. All right, guys. So that's about the tubectomy. So that's all for now, guys, and I hope all of you are reading very well, and I want you guys to understand the importance of reading regularly even now, and don't pick up any new books, don't do any more grand tests, and don't do any question banks. Whichever app you're reading, please, any source which you have, any good source you have, any small source you have, please do not go and do a question bank now. please concentrate, if at all, on PYQs, whatever time you have. See as many questions which have come in the exams. Sometimes the choice is not recalled so well, but still you know the topics which have come. And God forbid, if you've not done some topics which came in the last 3 years, if you've not done those topics, you still have time to those, understand those few topics. So please do only PYQs for now and revise regularly. Keep reading. There's no way that you will complete the course and say that I have done it all. But there is one shortcut to glory, and that is read the notes of your favorite teachers, whoever has taken your class, and whichever subject you like, whichever teacher, those notes, that teacher's notes, please complete all of them. Those 19 notes, when you complete, you'll have a sense of completion for your exam preparation. So do that and do a very good exam, guys. Best wishes, and I wish all of you pass your exams and get very good results. And those who are writing the NEET PG exams, I want all of you to get very good marks and get the PG of your choice. Best wishes, guys. God bless.